My pleasant duty to introduce, he doesn't require any introduction at all, Professor Sreenivasa Murthy, sir. And he is a national EC member RSSDA and involved in many international and multicentric trials. He is going to talk about drug, diet and diabesity approach in type 2 diabetes. Very practical session this will be, very interesting for the clinicians. Thank you.
Thank you, sir. Good morning and வணக்கம் தமிழகமே. Shanmugel sarke, Murli, Balaji, Chandru, and above all Anand Moses sir. Thank you, and of course the star GVK sir. We were missing him in the national forum from some time, so hope you will come back. கூப்பிட்டதுக்கு நன்றி. இது வந்து diet, drug and diabesity. This is what I'm supposed to be talking about, and I'm sure this topic would be given by Shanmugel sir only. It's a modern epidemic, we know. It's linked with various pathophysiological mechanisms which revolves around the insulin-resistant and hyperinsulinemia. And it was first coined by Sims et al. I think we should remember the great people who have invented and coined it also. We know the diabesity epidemic in our country, 9 out of 10 people with diabetes are overweight or obese, and 1 out of 3 Indians are overweight, have diabetes. And this is the burden we have today in our routine clinical practice. And of course, we know the greater the weight, the greater the risk to develop diabetes, and that is to the tune of 22 times. And of course, visceral fat, just to talk about Balaji's earlier lecture was alluding about the triple G and the double G, where the dangerous fat is the visceral fat, that is what you have to remember, and about 200 odd diseases have been attributed to that. And this is the pathophysiological link regarding the crosstalk between the obesity and diabetes. Basically, the inflammatory, the adipokines versus insulin resistance eventually would result in endothelial dysfunction and the micro and macrovascular complications. Now, we know with every 1 unit of rise in the BMI, the probability of developing being a diabetic increases by about 1.5%. And this is in individuals without diabetes, it's 0.5%, whereas with diabetes, it's about 1.5%. And there is a greater risk of developing this diabetes with a higher BMI, both in women it is more, and of course in men also. This is a prospective cohort study which showed the relationship between the BMI and the risk of developing in about 1 lakh odd patients. Now, why is weight reduction is important? Because we know the weight reduction improves the insulin sensitivity, preserves the beta cell functions, and to achieve beneficial effects on the glycemic control, as low as 5% weight loss is enough. And for each kg of weight loss, there is a A1C reduction proportional to about 0.1 point. And that's very, very important. And the balancing this glycemic control and the obesity risk is a challenge in routine clinical practice, and for which we have some of the anti-diabetic medicines which add to the fuel which are related to the weight gain. And of course, weight reduction improves the diabetes control, which is proven way beyond. The greater the weight loss, the greater the reduction in the A1C and the fasting blood sugar. Of course, weight loss reduces the diabetes risk over 10 years. And this is a diabetes prevention DPP program where about 3,000 subjects with pre-diabetes were randomized into 2 groups, intensive, and of course, the intensive participants achieved about 7% weight loss. And the more important, you should see the light blue color, and that is your lifestyle changes, which most of us fail to implement or to incorporate into our patient's lifestyle. The lifestyle modification can bring down the A1C to the tune of above 1%, and which many drugs will fail to reach that stage, but this is the healthy lifestyle which can give rise to that, and that is something which we should spend little time with our patients to do that. And of course, weight reduction leads to diabetes remission. This is one of the very famous trial called DIRECT, where the weight management program with the best standard of care, they saw that the greater weight loss led to the greater proportion of patients achieving and maintaining the remission, that is about 1.25 odds ratio with the diabetes remission at the end of 2 years for every kg weight loss. And that's something very important. There are various benefits of weight loss in people with diabetes and obesity. And of course, as you can see, it can manifest with the reduction and the improvement in the lipid profile, the sleep quality, proteinuria, albuminuria, hyperglycemia and remission, CV mortality, and of course, even the blood pressure. This is a look-at study which showed that 10% weight loss can have a 21% lower risk of composite outcomes in 1 year of time. And it's primary and secondary outcomes. Both are statistically significant numbers. And of course, you can also have the beneficial effects on the blood pressure, the TG and HDL and LDL also. So the loss of as low as 5% body weight in the year following diabetes diagnosis was associated with the improvements in the risk factors and 48% lower hazard at the end of 10 years. Now, this is very important slide to talk about what are the advantages you get with the percentage of weight loss. You can see there 5% can help with hypertension, hyperglycemia, 5 to 10 with the prevention of diabetes, NAFLD, PCOS, dyslipidemia, and 10 to 15% CV disease, urinary stress incontinence, NASH, etc. More than 15% for sure diabetes remission, CV mortality, and FPEF also you get advantages with that. But the problem is, this is the normal people who lose weight, but people with diabetes lose less weight. And these are the various problems associated with the diabetes, where the sedentary lifestyle, the reduction in the glycosuria, stress burden of diabetes, fear of hypoglycemia, binge eating, compensatory eating, and of course, various medications which can cause weight gain. To tackle this, we've been having these dietary recommendations. You can see the history of these dietary recommendations, where the low-fat diet popularly was introduced, then the food pyramid was introduced, then the My Plate was introduced, and of late it is the Mediterranean, vegetarian, and the DASH diet which has been done. And of course, WHO clearly recommends the intake of the carbs should be primarily from the whole grains and vegetables, fruits, and pulses. And the strong recommendations you can see on the left-hand side, and the conditional recommendations for children also, it has been clearly given. The dietary guidelines recommends that the carbs should be about 45 to 65% of the total daily calorie intakes. And this is all the various diets which are available, and the advantages we have just outlined on the right-hand side, where with these various diets we can attribute the advantages. Just to talk about few words about the low-carb diet, that's called LCD. ADA defines the LCD as a daily consumption of 25 to 45, just to remember, 25 to 45% of the total calories from carb sources, and while consuming less than 26% is called as a very low carb diet. And the VLC dietary goal would be to induce nutritional ketosis, and the LCD allows approximately 150 grams of carbs per day. Usually ketogenic diet prescribed allow only 20 to 40. That is the keto diet which already going off now. The more restrictive diets allow only less than 20 grams of non-fiber carbs per day. And this ketosis, which is nutritional ketosis, induces curbs the appetite in the form of nausea, vomiting, fullness, the increased acid load that can aggravate the bone loss and deficiency of various other nutrients. These are the merits and pitfalls about the low-carb diet. We know the merits, but the pitfalls would be it eliminates certain nutritious food items. It may be associated with a higher risk of mortality and a longer duration. Ketosis associated with the halitosis, which is again a problem, and nausea, vomiting, which is again a blessing in disguise as a side effect for many morbid obesity patients. And curbing carbs with the soluble, insoluble fibers, and this is a relationship to show that the U-shaped association is seen in these two studies, where the overlapping and continuous relationship, you can see the safe limit would be about 40 to 60%, above or below, both can give rise to the all-cause mortality benefits are waned off. This is what I was talking about. The long-term LCD, the NHANS study suggested that a positive association between the long-term LCD and the risk of stroke mortality. Now, this is how you need to manage the obesity in general. The first thing is about the lifestyle interventions in the form of diet and physical activity, which I showed you in the direct trial, the advantages of the lifestyle changes. Pharmacotherapy, metabolic surgery are the other options, and invariably most of the patients end up with the pharmacotherapy. Based on the BMI categories, the weight loss management should be categorized, and of course high frequency counseling, behavioral strategy, nutritional plan that can create an energy deficit regardless of the macronutrient compensation. Nutrition supplements have to be taken care. And in diabetes and overweight or obesity, the preferred pharmacotherapy should be SGLT2s and GLP or GIP and GLP combinations. And the weight loss medications are effective as an adjunct to diet and physical activity. Please remember that. And of course, behavior counseling plays a very important role when the patient has to continue for a long therapy. And of course, the response to the weight loss medication, you need to figure out in about 3 months. If there is no loss of less than 5%, then it is a failure. Then it may not give you the advantages when the early response is insufficient in such patients where the weight loss is less than 5% in 3 months, and consider discontinuation of the medication and evaluate alternate medications or treatment approaches. These are all the various nutritional management of obesity used in the practice, various diets. The low GI, high fiber content is something which is recommended in general, and that is what will help our patients. Of course, we do face challenges whenever there is a lifestyle intervention, because most of our patients, and because of our cultural problems, we end up not following this lifestyle intervention consistently. So 8 out of 10 patients require additional interventions apart from the lifestyle. 50% of the patients return to starting weight the starting weight within 5 years after starting the lifestyle modification. And of course, people on lifestyle modification can gain up to 35% of their lost weight in just 1 year. And that's the bad thing about this lifestyle intervention. And of course, the progression of diabetes with different interventions, you can see in this study, those who attained the NGR at least once during the DPP compared to those who consistently had pre-diabetes stratified by the treatment groups. And this is where you have the lifestyle, pre-diabetes, lifestyle, metformin in pre-diabetics, all that. And the pharmacotherapy, in addition to diet and exercise, can help our patients to achieve the clinically relevant weight loss. That's something very important. And this trial assesses the efficacy and safety of once weekly subcutaneous semaglutide, which is not available in our country, though for trials we did use. But this is something which is shown in this. So in people living with diabetes or overweight, we need to minimize the medication load, prioritize the medications with beneficial effects, and consider the anti-obesity medications along with the lifestyle intervention, and based on the risks and benefits, prefer GLP-1s or the dual agonists, and re-evaluate regularly and intensify the treatment. So these are all the effect of anti-diabetic medications on the body weight, the GLP-1s, SGLT2, metformin, and DPP-4 alpha-glucosidase inhibitors, AGIs, are weight neutral, and insulin, sulfonylureas, meglitine, TZDs are the groups which you should think about. And of course, the guidelines now have gone to the tune of recommending these drugs at the baseline with the very high efficacy. You can see the semaglutide injectable and the tirzepatide, and then the high efficacy is dulaglutide, liraglutide, and intermediate is of course the SGLT2, and neutral they were mentioned clearly. This is the ACE guideline, which talks about the anti-obesity medications, which has to be considered in people with diabetes, living with diabetes, and these are all the effects, how these cause weight loss, and the advantages with the CV benefits. You should look at the SGLT2 and the GLP-1s. And this is the GLP-1 RA and semaglutide, which has got the CV and metabolic effects, which are beneficial to the pleiotropic benefits, and this is how the GLP-1s act upon. And of course, Balaji covered these topics. The GLP-1 RAs harness the effect of GLP-1 for therapeutic use, both in the obesity and diabetes, and the oral tablet and the injectable liraglutide is available, and of course dulaglutide is not recommended as anti-obesity. These are some evidences to show that the weight loss is efficacious and it is sustained over a period of time. These are subjects on semaglutide 2.4 mg once weekly achieved with the weight loss goal, the STEP trials which are talked about, and the improved glycemia. 7 out of 10 achieved less than 6.5% of the A1C. 8 out of 10 achieved A1C of less than 6.5% as well. And these are all the cardiometabolic markers, which are the ASCVD risk factors, so-called, are reduced with this. And of course, significant reduction in proportion of subjects with prediabetes also has got a role with semaglutide. And tirzepatide is a dual agonist, which is a novel ligand with agonist activity for both GIP and GLP. And the GIP targets the white adipose tissue, which is very important for us, and the GIP component of dual GLP and GIP receptor agonist. And this, you can see on the right-hand side, the effects of GLP and the GIP. For want of time, I'll skip. These programs were called SURPASS, which is basically to demonstrate the tirzepatide 10 mg, 15 mg weekly once for non-inferior to sema, 1 mg once weekly for mean change of A1C. These are all the trials which showed that it is non-inferior and superior to semaglutide whenever it comes to the tirzepatide. Definitely it scored over. And SURMOUNT-2, we were part of the SURMOUNT-2 trial where about 23 subjects were recruited from our center out of 29 from India. And in trial and on treatment, this is beyond also, they overlapped with a real world kind of a study after the study was closed out. And the GI side effects, of course, there are mild to moderate. The diarrhea, the GI, upper bloating, vomiting, nausea are some of the troublesome. And there were no withdrawals because of the severe GI effects also. And carglutamide, semaglutide combination, Cargisema, we are doing Reimagine 2 study now, which is ongoing, which is again amylin derivative, again for weight loss and in diabetes we are looking at once weekly. This is a combination of carglutamide and semaglutide. And the Cargisema appears to have a safe and well-tolerated profile in phase 2 and phase 1 studies are already there, and phase 3B we are doing it now. And these are all just to talk about the anti-obesity medications approved by the FDA, and technically we are just using Orlistat occasionally. Now the GLP-1s, SGLT2s, we are using it, though SGLT2 are not indicated, but this is the liraglutide and the Orlistat, which we are showing the comparison. And of course the other drugs we hardly use, and they have this prevention of diabetes complications advantages, and with the risk of complications comes down, which can be in the form of BP control or the lipid control. And this is the retatrutide, which we are again doing a study called TRUMP2, which is once weekly injectable triple hormone, where this is targeting basically about the hepatic liver metabolism, which is the glucagon receptors are there, and the weight loss mechanism may be complementary to those with the other incretins and the insulinotropic effects of glucagon-like component of the overall salutary effect on the glycemia. And this is something which I wanted to show. And the metabolic surgery, bariatric surgeries, of course, there are 3 types. There are remission associated with LGB is the highest among all these 3. And of course, finally, the optimizing weight management in people with diabetes would be permission, talk to your patients about their weight, understand the cause of obesity, look at the barriers, avoid the stigma, explain the importance of weight management, the advantages, what they get. And decision making has to be sharing basis, it has to be bidirectional, motivational interviewing, set realistic goals, don't try to jump into conclusions, and don't set the patient up for multiple cycle of failures and escalate treatment and consider the use of pharmacotherapy. And this is just to show you the future directions with the obesity molecules. Plenty of them. The PYY is something which is going to come up, the amylin agonist, and of course the GLP and glucagon agonist also people are trying. And the GLP, GIP, glucagon is a very promising, at least the weight loss, 15% and beyond is 84% of the patients have lost. Thank you very much for patient hearing, and any questions I'll be very happy to answer.
Thank you, Dr. Sreenivasa Murthy. Actually, you have got an interesting practice.